a 36-year-old gentleman, businessman by occupation from Gwalior, Madhya Pradesh, presented with complaints of bleeding per rectum about 4 months ago. Coming to history of present illness, he was apparently asymptomatic 4 months back when he noticed bleeding. It was initially painless passage of fresh blood mixed with stools, more towards the beginning of the stool, insidious in onset. Initially, once every 2 to 3 days, this bleeding episode was once in every 2 to 3 days. Later, he noticed this with every episode of stool. The quantity of the bleed, it was small, with about 10 ml per episode. There was history of sensation of incomplete evacuation of stools. It is not associated with any pain, perianal discharge, mass per rectum, perianal fullness. There was no history of trauma. There is no history of altered bowel habit or change in stool caliber or mucus in stools. There is no history of incontinence to stools or gas or history of soilage of undergarments. There is no history of urinary complaints also. Patient also had no dizziness, weakness, or no history of previous blood transfusion, no history of abdominal pain, distension, vomiting, or constipation. There was no history of jaundice, loss of weight, loss of appetite, breathlessness, or bony pains. Coming to treatment history, sir, for the above complaints, he was evaluated elsewhere with colonoscopy and biopsy and was told that he had a cancer of the rectum. He also underwent MRI and CT scan of the abdomen and was advised radiotherapy, which he received at Gwalior over a period of 6 weeks, 30 cycles along with a oral medication at the same time. And during treatment, he experienced no significant adverse reactions. He tolerated the treatment quite well. He also noticed that the bleeding PR reduced from before and stopped after around 2 weeks after therapy. Coming to past history, he had no medical comorbidities and no previous surgical history. Personal history, he takes mixed diet. His appetite was normal. He's a non-smoker, non-ethanolic. Bowel habits, as earlier said, regular, not altered, and bladder habits are regular. Family history is non-contributory. There is no history of cancer in his first or second degree relatives, and no history of any allergies. To summarize, he's a 36-year-old male with complaints of bleeding per rectum 4 months ago, which is painless and mixed with stools, an incomplete sense of evacuation, and for which he went to a local clinic and was diagnosed as rectal cancer and took neoadjuvant therapy. Shall I proceed to examination?
Any questions? What do you think, or based on your this history, what is your impression? What is your diagnosis?
Sir, since he had a biopsy proven cancer and underwent neoadjuvant therapy also, it's probably C rectum, locally advanced C rectum.
Okay. Any questions? No. So I think she has covered everything. Ajay? Just say, so you can now say proceed with your examination.
Sir, on examination, he is conscious, cooperative, well-oriented, well-built and nourished. He has a good performance score, sir, ECOG PS0, and a BMI of 23.5, height of 170 centimeters and weight of 68 kg. There is no pallor, icterus, cyanosis, clubbing, pedal edema, or palpable lymphadenopathy, left supraclavicular node or generalized lymphadenopathy. Vitals is stable, sir, pulse of 86, BP 120 over 80, afebrile, and respiratory rate of 16 per minute. Coming to abdominal examination, on inspection, his abdomen is flat, umbilical is central and inverted, All quadrants are equally moving with respiration. Flanks are not full. No scars, sinuses, dilated veins, abnormal pulsations or visible peristalsis seen. Hernial orifices are normal and external genitalia are also normal. Coming to palpation, abdomen is non-tender, no organomegaly, hepatosplenomegaly or mass palpable, and other inspector findings are also confirmed. On percussion, sir, liver span is 12 centimeters, no obvious free fluid, and on auscultation, bowel sounds were normal. Other system examination was also essentially normal. I'll move on to rectal examination. He has normal perianal skin, no soilage of undergarments were noted. No on examination, external examination, there is no sinus or fissure or skin tags noted. Uh, Anal tone was normal. Proliferative growth was noted around 4 centimeters from anal verge, which was extending from 4 o'clock to 7 o'clock in the posterior wall. The surface and margins are irregular. It is firm in consistency and overlying mucosa was fixed to the growth. The examining figure could not reach the upper extent and no other palpable masses were felt. Glove finger was stained with stools.
Uma,
Yes, sir.
4 to 9 o'clock, but you said 7 o'clock.
Oh, 4 to 9 o'clock, sir.
Okay.
And it was glove finger was stained with yellow stones. To summarize, sir, is a 36-year-old businessman with no known comorbidities, presented with painless bleeding per rectum, and was diagnosed as rectal cancer and took chemoradiation. On examination, he is hemodynamically stable, good performance status, with a digital rectal examination showing a proliferative growth from about 4 centimeters from the anal verge, extending upwards, and it was non-bleeding to touch.
Now, as you, in this case, you previously as know this is a patient of carcinoma rectum. The diagnosis is confirmed before the examination, even on the history, it is confirmed. And now the patient underwent this chemoradiotherapy. Now, how will you proceed further? As you know, all these things, he's having carcinoma rectum on examination, is basically rectal tumor of upper, mid, lower. Where is the situation? You think this is a locally advanced carcinoma rectum? Lower rectum, probably.
Lower rectum.
Okay. Now, how will you proceed further?
Sir, I would like to just review the previous records for to know the exact treatment and staging.
Okay. What previous record you will look for?
So mainly imaging said that MRI and CT, CEA levels, pre-treatment CEA levels, and other investigations for general fitness.
Now proceed further. Tell me it's all the reports.
So what's the report now?
Sir, colonoscopy was done for initial biopsy, which showed an annular proliferative growth in the distal rectum. Rest of the colon was normal. Biopsy was taken from that, which showed signet ring cell and mucinous predominant adenocarcinoma.
Do you think this colonoscopy report is complete? What do you make out of this colonoscopy report?
Sir, it was non-obstructing. The scope was negotiable when they mentioned about the rest of the colon.
Yeah.
And probably no pre-existing inflammatory disease of the colon. And
other than
what else do you see?
Any synchronous lesions, if they are present, they are not documented in this.
What is the total? You can see you haven't mentioned the distal, the exact length of involvement of the rectum.
Yes, sir.
Is what mentioned in the colonoscopy or not?
No, sir, it's not given.
Those we can say this is not a complete colonoscopy. So you have to mention what is the lower margins from the anal verge and how much is the extension of the growth.
Okay.
Next.
Okay. CT abdomen was done, sir. However, the report was not available. This was just we got it in a written record. This thing in his OPD papers. CT abdomen
So
showed us,
why the CT was done?
sir, for to look at any abdominal metastasis, abdominal and probably chest, since any liver metastasis or metastasis, ascites, any other peritoneal nodules or a mental nodule.
We can directly say to look for the M1 disease.
Yes. No.
Okay. Anything, sir? One.
You said chest. No, you said chest. How will you see lung metastasis on CT abdomen?
So CT abdomen and chest also should be done ideally.
Yeah.
This is a simple investigation for ascites.
Sir, sorry.
We need to look for ascites.
So we can visualize any ascites if it is present, sir, on cross-sectional imaging.
Investigation we want to look for ascites.
So preliminary, we can go for an ultrasound to rule out any gross liver metastasis and ascites.
CT is not done to look for ascites. And how many days of CT can you see peripheral metastasis?
Sir, for peritoneal mets.
Yeah.
Sir, if it is not very sensitive, sir, but if it is gross peritoneal disease, we can see it in CT scan.
Okay, I think that will you have something on other investigation to show that it's a disseminated disease rather than going for a CT scan?
Sir, if you are suspecting disseminated disease, is that what you meant?
That's what you are looking for. You said in CT scan, M1 disease. You mentioned that. That's what I am asking. Otherwise, that's not my question. I am asking your answers.
No, sir. If we suspect gross metastatic disease, we would go initially for an ultrasound abdomen and a chest X-ray. But we prefer CT to look at the liver metastasis and smaller lesions if we are missing any, sir. And CT chest for pulmonary metastasis.
Investigation by sonography or CT scan? I would do a sonography if it shows the liver metastasis, that shows metastasis already. If it shows ascites, it shows ascites. If it shows large nodular lesions, it shows lesions in the omentum. If it shows large nodes, it shows large nodes. Sonography shows all those things what you are saying on CT scan. So what are you looking at CT scan now? It is a carcinoma rectum.
Yes, sir.
And post neoadjuvant chemoradiotherapy.
Yes, sir.
How much time after the chemoradiotherapy?
Sir, sorry, I didn't get that, sir.
How much duration after the chemoradiotherapy?
Sir, he took the chemoradiotherapy from April to May ending, sir, 27th of May. So it's almost 2 months past the therapy is finished.
So he was given a definitive chemoradiotherapy or a neoadjuvant chemoradiotherapy?
Sir, neoadjuvant.
What is the difference between a neoadjuvant and a definitive chemoradiotherapy in clear rectum? How did you assess that this is neoadjuvant? How did you come to know? What are the protocols of neoadjuvant radiation therapy for clear rectum?
Sir, it's either a short course radiation therapy or long course long course chemoradiation. Sir, sorry.
What did he receive?
Sir, he received a long course chemoradiation therapy.
And how many cycles of chemo?
Sir, chemo he has received oral capecitabine, sir, along with 30 cycles of radiation.
Only capecitabine, nothing else other than.
Only capecitabine. No, sir, only capecitabine.
So, will you look for anything else on CT scan? Now, you have done a CT scan to see for resectability or to see for dissemination?
So, to resect, we can look mainly at the resectability and also at the metastatic disease, sir. But in rectum, especially in lower rectum, MR is preferred over CT
Yes. Why is MR preferred over CT?
because it correlates with the pathological stage more closely, and we can get a better information
Which
of
stage? Which stage you want to say?
advanced
MR will
stage.
be
So if
better
it is
for which stage?
so
Which stage?
T3
T
and
or
above,
N or M?
T and N, sir.
It's good for T.
T, not for L.
Okay,
N is equally good looked in CT scan as well as in MR.
okay, sir.
T staging
T,
is better seen on MR.
yes.
So you want to look for good T staging that you anticipate. So pre-chemo radiation therapy, what was his T stage?
So pre therapy, his T stage was T3A N0.
T3 N0. So now
Yes, sir.
what do you anticipate? What do you anticipate now?
So the T stage might have reduced or might have been the same. We'll to
It
see
can
with
be
the
three things.
repeat MR.
It can be three things. Either the tumor has responded to the chemotherapy, so T3
Yes,
will become T2 or T1.
yes, sir.
If it is not responded, it can remain T3 still.
Yes, sir.
If it is not responding, but the tumor is growing, it will become T4 or it can be
T4 also. Okay.
or it
Yeah.
can be
Because
so it can, so now will it make a difference? Suppose it is T3 disease versus T2 disease, will it make a difference for a resectability? Because you already see the new adjuvant. Suppose I say it is a responder, it has become T2. How will it change your plan?
It's in lower rectum. Yes. In lower rectum, we may consider doing a sphincter saving procedure, sir, especially in a young patient like this. If it is responsive and the tumor has shrunken into a T1 or T2, we may consider doing a sphincter saving procedure.
So lower rectum means you need to say close to the anal sphincter.
Yes,
Close to
sir.
the anal sphincter. That you are not shown on colonoscopy. How much closer it is to the anal sphincter?
Yes, sir. The pre-treatment MR is available. I was just going.
But we are still discussing on the history what we have. We have not seen
Yes,
your
sir.
MR or CT. We are still discussing on the history.
Okay,
What
sir.
was your information that where the tumor is on your PR and on your colonoscopy?
so 4 centimeter, no?
4
It was
centimeters
the
from
4
that.
centimeter
4
from the
centimeter from the anal verge.
So 4 centimeters from the anal verge. If it is T3 lesion, do you think that you can do a LAR?
Sir, if it has responded and shrunken, maybe after cross-sectional imaging and like MR, we may consider doing an intersphincteric resection, sir. If not
It is again the
LAR.
same question. If it is T3 lesion following the neoadjuvant chemoradiotherapy
Yes, sir.
at 4 centimeters from the anal verge, will you consider doing a LAR? Yes or no? We'll have a discussion after that. Definitely, in either case, we can have a discussion. It can be a good discussion in either direction. Don't take it as a as a criticism to what you are answering. But it is
Yes,
whatever you answer, you will have a question beyond it.
yes.
It can be discussion in either direction. So, give an answer which you are more prepared for.
No, sir, not an LAR.
So, what will you like to do if it is T3 lesion at 4 centimeters?
Probably an intersphincteric resection, sir, after counseling the patient.
Okay, so you can do an intersphincteric dissection. So, will it make a difference if it is T3 lesion? Since you are already prepared for an intersphincteric dissection in T3 disease right now, and you know it is a T3 disease, will it make a difference whether you do a CT scan or an MR now?
Sorry, sir, I didn't get
It
that.
is already a T3 disease, you told is pre-operative,
Yes, sir.
pre-chemoradiotherapy.
Yes, sir.
And post-chemoradiotherapy, if it has responded, it is again a T3 disease. You are planning a ultra-low anterior dissection, that is the intersphincteric dissection.
Yes, sir.
So, how is which investigation is going to help you and how it is going to help you now?
Sir, I would prefer a MR of the pelvis, sir, because to look at any involvement of levators or if how to what extent if they are involved.
Very true. I think what you are saying is absolutely correct. And why CT scan? Why have you got a
So,
CT scan done? You are telling absolutely correct that MR is
yes,
good application because you want to do ultra low anterior section, you want to do intersphincter dissection, which will give you the sphincter anatomy very clearly better than CT scan. Then why CT scan?
so, no, sir. This was a pre-treatment CT scan, sir.
He hasn't got. They haven't.
So basically, you were telling us the
This is the previous records.
yes, sir,
This
previous
is a
record.
previous record.
Now you can say on the
Yes,
time
sir.
of CT
This,
scan, on the time of CT scan, you can say this is a CT scan which was done previously, or you haven't shown us the ultrasound report.
yes, sir.
You have directly gone to the CT scan. The criticism was comes to why the CT scan was you are showing directly. Is there a ultrasound was done or not? Okay.
No, sir. Actually, we only got few written handwritten papers. Only these few information were available. Ultrasound CEA was also not available for pre-treatment. Only CT, the few lines were written, and we got an MR report. That's it.
No, but whenever you are presenting a case in a thing, then you must say, sir, I would have done the ultrasound first, but unfortunately, this case was investigated and treated before it came to us, and ultrasound wasn't done. So then it means that it shows that yes, your approach would have been this rather than see. So what Dr. Anand is saying that when you are presenting a case, the ultrasound has an importance because there's an easily available investigation. It doesn't require any preparation. Say
Okay.
Next, move further.
next
slide.
next slide. Uma, क्या हो गया भाई देखो तो
The internet loss.
तो कोई हिस्ट्री में और कुछ भी कोई क्वेश्चन में कैसे करते हैं
Your 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 slide is not moving, Uma.
Can you see?
Now
something wrong because इसकी आवाज भी
your internet connection is not good. Probably, I think.
I don't know. There's a very high. I don't know how many people have done that.
It is such a percent
वो ऑपरेशन है तुम ऐसे सोच रहे हो मुझे में सब डालना है कर दो डालेंगे पहले भी इसका सेंटर रूल है हाँ कभी नहीं करते वो जो टोटल कंसेप्ट बेकार है
Uma,
उसकी पॉलिसी तो मेरी फंडी नहीं है जो भी तुमने डाइवर्जन स्टोमा बनाया है कभी बंद नहीं
I देखी
उसका भी चल रहा है बिल्कुल नहीं करी ठीक है तू तो मूव हो रहा है मैं भी मूव हो रहा हूँ हमारा पंखा भी चल रहा है तो पंखा किसका चल रहा है उसका नहीं चल रहा है यस हमारा तो चल रहा है हाँ चलने लगा
Uma, next slide, please. अभी तक भी म्यूट ही है.
नहीं अभी थोड़ा चली थी वो आगे
Hello. Can you see? Can you see my slides, sir?
यस
Yeah. So this is the pre-procedure, pre-therapy MRI.
Yes, sir.
Can you tell us the findings in the images?
Yes, sir. These are axial sections showing tumor, sir, almost circumferential tumor, nearly circumferential, with intact CRM, sir. CRM doesn't seem to be involved, and there is one area of suspicious involvement of the mesorectal fat. So that's why it is probably T3, sir.
What is the location of the tumor in this image?
In this image, this is mid to lower rectum,
No,
so
no,
mid
this in
rectum.
the circumference. In the circumference, what is the
So,
in the clock? Tell me.
4 to 2. है ना?
Clock face. No, sir. Clock face is it's nearly circumferential, sir. It's from almost 2 to 5.
4. 4.
So because of tumor time, this is tumor.
Hello.
Yeah. You can put your cursor there and tell me the side of the tumor.
Hello.
Hello.
So this, can you see my cursor, sir?
Yeah.
Hello. Can you see my cursor, sir?
Yeah. Tell me the side of the tumor in the circumference.
Sir, it's on the right side, sir. From around 1 to 2 o'clock to almost 4 o'clock.
In the third image, I can see the tumor in from 1 o'clock to approximately 5 or 6 up to 5 or 6 o'clock.
Yes, sir.
So what other things you can see in this image?
So the CECT is intact. This tumor is just entering the mesorectal fascia at one point.
There is a breach
So
in
it is
the
T3
9 o'clock
probably.
position.
Yes, sir.
In the 9 o'clock, you can see some thinning.
Yes, sir.
And a small, probably I can see a node at approximately 3 o'clock. Probably it's a node.
This one.
3 o'clock. 3 o'clock. No? This is basically this is a T2 wetted image. Fat is suppressed. You can see a fat is bright. This is fat set image. You can you
Yes, sir.
show us another image in the fat looks black. Can you have some more images?
This one, sir. And I have a small video also.
Okay.
This
It's not moving.
gradually.
It's not moving.
The video is not playing, Uma. Uma also not please. That's what I'm saying.
Not moving.
Yes, now it's
Yeah.
yes.
So how will we classify the tumor in MRI imaging? The T1, T2 or T3? How can you say which stage of tumor?
Sir, in very early T1 and T2, MRI is not very sensitive, sir. It is more sensitive for locally advanced tumors like from T3 onwards. If the tumor is
So which is the best modality for T1 or T2 disease?
sir, endorectal ultrasounds.
Okay.
So once it crosses the rectal wall, that is when it becomes T3 and starts involving the mesorectal fascia. Sorry, mesorectal fat. It is more MRI is more sensitive.
So in this MRI, the tumor is T3.
Yes, sir.
Mesorectum we can see the mesorectum completely, na circumferentially pura.
Yes, sir.
Circumference and some nodes in the mesorectum. The plaque.
I think in the at two places, one is at 9 o'clock and other is at between 2 and 3 o'clock. It appears that the lesion is maybe infiltrating into the but it has caused the CRM. And there are few nodes. I think these are two only important things which I could get from your MR.
Okay.
And maybe these are the two main things which I will be looking at in subsequent MR which I will do after post radiation.
So, subsequent MR, we have only couple of images. So this is all pre-treatment.
Yeah, this is pre-treatment. So if you do it post-treatment, these are the areas which I will be very keen to look how it has responded in these areas. And at one place at 6 o'clock,
Yes,
it appears like a nodularity, which might get breached. It appears that that is a site where the tumor is present at one of the images which you have shown. Go down. Yes, here.
Hmm.
At 6 o'clock position.
Okay.
And other thing which you look for in the MR, surrounding structures.
CRM, sir, and EMVI and sphincter involvement, sir.
Do you know how to measure CRM? The center of the tumor
and peritoneal reflection also, sir, if it is involved or how far it is from that. Here I can see the peritoneal reflection.
Other also you look for it's a male patient, the prostate seminal vesicle.
Yes, sir.
You should say the local involvement of prostate in seminal vesicles. Okay, tell me the report of this MRI.
This is the reporting, sir.
Okay.
Semi-annular mucinous mass with smooth border from 5 to 7 o'clock position for a length of 5.9 centimeters. Distal edge is 6 centimeters from anal verge. Proximal edge lies below the peritoneal reflection. And tumor extends through muscularis propria, extramural spread of 4.7 mm. No suspicious nodes, EMVI negative, CRM is clear. Closest margin 3 mm at 6 o'clock position. No pelvic sidewall nodes. And they staged it as T3A, N0.
What is GMBI?
Extramuscular venous invasion.
Extramural vascular invasion.
So basically it's a T3A tumor with node. There is no nodes in the mesorectum. Previously was saying that the node is visible in the rectum, mesorectum.
So nodes on the size criteria, probably they have, we could see some nodes visible, sir, but as if it is less than 8 mm, it is not definitive for CA metastasis.
It is not correlating. The distal anal verge length margin is 6.3 centimeter. In a
Yes.
PR examination and your colonoscopy, there is a 4 centimeter. There's huge difference in the.
Yes, sir. Yes, sir. There is difference, but this is pre-treatment MR, sir. But I have examined the patient only after neoadjuvant therapy.
Okay. So, do you have any imaging?
So you mean to say it has increased?
Might have, sir, probably, but we don't know the findings before that. They were not documented.
No, MRI finding is there, and clinically now you have examined.
Yes.
It has come to 4. It means it has increased. I mean,
Yes, sir.
that's the inference.
Yes, sir.
So after the treatment, what are the consequences of this disease? How can you follow this patient after? How will you evaluate this patient further?
Sir, post treatment, we get an MR, sir, after 4 to 6 weeks.
Only
And
MR?
also for the distant metastasis, we can do an ultrasound and chest X-ray and CEA levels.
Is there a role of PET scan in this patient?
Yes, sir. PET scan can, we can go for PET for whole body screening in the one go.
No, in the pre-treatment or post-treatment only?
Yes, sir. Pre-treatment also we can go for an
So I can ask you what is the role of PET scan in case of carcinoma rectum, pre-neoadjuvant and post-neoadjuvant? Is there a role of PET scan?
Yes, sir.
I think no. Study.
Is it established modality to do
No, sir. It is not recommended as per guidelines, but maybe it can be used.
In the NCCN guideline, I think this is not written. The PET is not recommended. They have written regarding the CT chest, CT abdomen to look
Yes.
for M1 disease and MRI pelvis for the local regional disease.
Has any NCCN guidelines written as a PET for requirement for any malignancy?
esophagus?
Annual canal esophagus planning. This was CA esophagus. It is coming up for CA GB coming time, and maybe any analysis.
CAGB is not.
GB में बात. So it is not being mentioned in the PET scan. If you say as an answer in your exam, you have to say as per NCCN guidelines it is not recommended. But what is your institutional policy?
Yes.
If your oncologist do it as a routine before a CA rectum, you have a strong support for your statement that this is our institutional policy. So our oncologists do it, so they get it done and pre-op as well as post-op, and then we get the patient for surgery. So we assess that in these two cases. If you see for guidelines, it is not yet recommended.
Yes.
So now I can ask, what is the indication of PET scan in CA rectum?
Sir, in resectable colon liver metastasis, to look for any extra other metastasis which are probably unresectable. To rule out any other metastasis, extra hepatic. Yes, to rule out extra hepatic metastasis, which preclude curative resection.
So do you want to say that when you are doing for a CA rectum area or a LAR and simultaneously in the same sitting you plan to do a liver resection, then it has a role?
Sir, if there is any extra hepatic metastasis, it precludes curative resection. So we don't undertake such a major surgery. To rule that out, the curative intent. If the intent is not curative, there is no point in doing such a major surgery. So to clear that, we do a PET.
Suppose you are having a CA rectum,
Yes, sir.
plan to do a ultra-low resection,
Yes, sir.
and you want to do a left hepatectomy in the same set, then definitely PET will have a role. If you are planning only to do a ultra-low resection in this patient without doing any liver resection, or you have no evidence of having liver metastasis on the other investigations, will there be still a role of PET scan? You said for liver resection, no? I think
Yes, sir.
No, PET scan is done for liver, or PET scan is more saying. You need to say that PET scan is a better.
Prior to liver resection.
Huh?
No, sir. Prior to liver resection, sir.
So what basically PET stain is good for stain.
Sir, PET is sensitive
What
in
is the
detect.
extra hepatic stain splash, if any?
Sir, I didn't get the last part. If I want to see extrahepatic,
Basically, you will do a PET
Spread.
scan to look for extrahepatic
Spread.
disease.
Disease.
yes, sir.
If you are planning a liver resection at the same time,
Yes, sir. Prior to liver resection,
if
I
you are
would
not
like a
planning the
PET.
liver resection in the same setting,
Hmm.
then you will go ahead with your resection.
Then I think we can just get an ultrasound or a chest X-ray before doing.
Next question comes, when will you do a liver resection in a patient with C rectum?
So if it is very small monosegmental or very small metastasis, we can undertake in the same setting, sir, even
Very vague answer.
in this particular case.
There is a specific guideline given for that. Why I was seeing your presentation in last 40 minutes, I was expecting a very good answer from you. You have done a very good presentation, and I was expecting a better answer. Mohan?
Any criteria?
Criteria,
Any
no,
criteria
for
given by
synchronous, say,
सही है.
Forms. Yeah, and what is the form score?
Sir, if the metastasis interval is less than 12 months, then multiple if there are extrahepatic lesions, then we should not go for extraction. If there are multiple segments involved, bilaterality of liver is involved.
Actually, the thing is, Oxford basically rules out resection, but it has got nothing to do with the time of resection. So there are three approaches to it. There is a synchronous approach.
Yes.
There is a metachronous approach, and there is also approach in which they plan to do the liver resection before the liver resection. That is
So now I come back to you.
but
Now there
these are
are
the
clearly three things mentioned.
liver
You
first,
can do a liver resection at the time of resecting the CA rectum.
that is synchronous,
You can do a liver resection after doing your colon resection,
or you can do before.
and sometimes you can proceed with the liver resection first and then colon resection.
Yes.
Now, do you have any? Definitely, everybody will not read everything, but do you have any idea about it? That if you can conclude, you're giving some concluding statement at this.
Sir, if the patient is obstructed, we would like to tackle the primary first, sir. And simultaneous resections can also be attempted if the patient is fit enough and not obstructed. Liver first is preferred because there is no chemotherapy induced liver dysfunction at that point, and the primary is not symptomatic, not bleeding or obstructing.
Does it relate to the volume of liver resection in all the three settings?
So
Does it relate to the volume of liver resection in the three settings? Pre-chemo, with pre-colon, at the time of colon resection and after the colon resection. Does the volume make a difference? Volume of liver resection required? These are all described only for C rectum, let me tell you. Okay, good. I think till now you have fared very well. You have cleared your exam, that is for sure. But I think to score better, you will require to have access everything because this is very well given in the convent book, which book there in Shuttlewood.
नहीं सर ब्लूमगार्ड में भी है.
What has also given this?
कौन सा भी criteria
टेक्निकली ना,
Repetitive with colon.
हाँ, उसके लिए उसमें ये फॉर्म क्राइटेरिया तो सी में दिए हुए हैं.
basically
latest book for surgical advances, पूरा chapter है.
और अभी सर्जिकल वाला
There's a latest book, sir, surgical advances आती है.
रोशना वाली,
This is from a foreign one.
और जो फॉरन वाली जो है वो क्या नाम था यार वो जो
Okay,
Next one,
good. Next slide. Let's go to the next slide. Just let's conclude because we are running out of time.
Yeah. So,
Anything that you would like to say concluding about this patient?
any more investigation?
One thing I want to clear. Just I asked earlier, what is definitive chemoradiotherapy and what is neoadjuvant chemoradiotherapy? What is the difference between two?
I'm not very sure.
So
There's
there's a dose difference in-
these two terms self-explain the thing.
there's a difference in the dose of radiation. Probably, I think.
Yeah, obviously.
But in this patient, how much was the radiation given and for how long?
Next,
So he has received
Next slide.
yes, he has received 60 grays of radiation, 2 grays per cycle for 30 cycles with oral capacity.
60 grains definitive, no?
Definitive. 60 gray is higher than recommended.
60 grains is definitive.
45.4.
Yes.
Yeah.
Plus 9. 45 plus 9.
45 is the radiation.
45 plus 9.
Plus 9.
So we got
Yes.
evaluating the expectations.
Long question. The total dose of radiation is higher than what is definitely recommended. So we can say this is a definitive.
Then they give that five resting only.
So what these are the basic questions that you will be asked again and again. That
This is
what
not
is the definitive chemotherapy? What is the definitive radiation therapy? What is the type of chemotherapy being given? How does capacity affect the surgical outcome? What are the other chemotherapy which you could have given as a better response? What is chemosensitizing the tumor? Why is the tumor being has the concept of having a neoadjuvant chemoradiation therapy in CECT? And then how to proceed with liver resection if required. And then if you answer all this, then the next question would come definitely of a lung resection. That is after you have passed your liver resection. So liver resection passing means you have already got 95% plus marks. Then you will come to lung resection. So that is also part to it. But you have done very well. Very well. Good presentation.
Thank you.
I think we shall conclude now.
Yeah.
We are running out of time.
Any more slides?
So routine investigations we have got it done, sir, which are
Okay,
essentially normal.
we'll conclude the session. Thank you.
Okay. Thank you, sir.
Thank you.